I'd like to welcome to the stage Kevin Patrick, who's been studying mobile health at the University of California, San Diego, Richard Liebowitz, who's the Chief Medical Officer of New York-Presbyterian Hospital, Dr. Usman Iqbal, the Head of Oncology, Global Evidence and Value Development at Sanofi, and Stefan Linn, the Senior VP of Strategy and Global Pharma at IMS. I thought that we might begin with you. We've heard a lot from people who have been thinking about connected care and about data, but you've been living this at New York-Presbyterian. I saw some figures this morning also in that special issue of JAMA that hospitals' IT budgets more than tripled from 2000 to 2010. Is that delivering value? How do you get value out of the technology investments that you're making, and how does that contribute to a more connected experience for the patient?
Thank you very much. It's an interesting question, and I'd actually like to back up a little bit. Earlier today, we heard a lot of sort of big picture, big data talk, and what I'd like to do is sort of bring it down to the lower level, sort of the base level. And from my perspective, the most base level is really in the room, the physician with the patient, and the connectiveness that needs to take place there. One of the things that I think we will all talk about is the role of the electronic health record. This, through obviously meaningful use, has had a huge impact here. If we go back before meaningful use, we were talking about maybe 3 or 4% of physician practices, hospitals being tied in with an EHR. And now, since the advent of meaningful use, we're up to 50% of practices and over 70% of hospitals. The question is, what has it really done? Well, understanding where meaningful use is in terms of stage 1 and stage 2, we're really not expecting changes in outcomes. At this point in time, it's about data collection, and it's about advancing processes. But the real question I have is, what has it done in terms of the interaction of the patient with the physician in the room? The thing that I hear most from physicians is the way in which it's been actually an obstruction to the care of patients. And I think when we talk about connectedness and we talk about where IT needs to go, I think we really need to address why that is. If you look at surveys that have been done over the last 2 years, from 2010 to 2012, there's been a significant decrease in terms of physicians' sense of the helpfulness of an EHR. Less of them would recommend EHRs, and less of them feel that it actually contributes to patient outcomes. So I think that what we really need to do from the value standpoint is understand, number one, how it is we get information to the physician who's in the room with the patient, how we use big data down for that patient that's there with them, how it actually affects the care of that patient, and how we do it in a way that doesn't actually interfere with workflow, but is actually assistive in taking care of patients.
Is that a first technology issue, and that the technology that was adopted just wasn't up to snuff, or does it have to do with the way it's been deployed?
I think it's a first technology issue. I think one of the wonderful things that meaningful use will do is, given the fact that we now have so much penetration of EHRs, is there's much more of an initiative on the part of industry to really take us to that next generation. When you're dealing with 3, 4, 5% of individuals who have EHRs, it's very hard to make the investment that you need. I think now the next generation of EHR hopefully will handle a lot of these problems.
Dr. Patrick, you've been working on mobile health. The M Health Summit every year down in Washington is a huge draw. There are always a ton of people at HIMSS. We've been talking about M Health for a long time. Is it actually coming of age? What are some of the challenges that you see, or is there still a gap between what people hope M Health will achieve and what it actually is doing?
Yeah, good question. And coming of age is a good way to state it, because M Health is really only a few years old, so it's really just an infant right now. And so to have expectations that a lot is going to happen right now with it is a bit premature. But I think all of us who are working in this space, and again, as a researcher that's been working in this space for actually over 11 or 12 years, I guess, there's a lot of excitement about this, a lot of potential work. And so we characterize our work as being in mobile. So it's the apps and all the things that can be delivered on this sort of computer that we're all carrying around. Social connectedness sorts of issues can also be ascertained using mobile devices, and also what we can understand right now with social networks that we couldn't understand 5 to 10 years ago because of platforms like Facebook or like Twitter, others. I mean, it's just stunning. If any of you haven't spent time with an analyst who's doing work in social analytics on these platforms, I highly recommend it, because it will knock your socks off as far as what you can learn about individuals for this. The third area that we're focusing on, so these are emerging areas that are going to coalesce, is design. This whole notion of how you design a user experience that in fact is something that people will use on a continuous basis. And this also is an exploding area right now, the maker movement, if you will. And I can tell you there's a lot of excitement on the part of the millennium generation to jump in, make things that work, that engage, that compel, that really allow people to do it. And again, a few years ago, we weren't talking about that, but we've got people like that in our group that are doing work. And then finally, the data, again, the big data, the data analytics. You know, a lot of discussion here at this meeting, rightfully so, is about the electronic medical record, about data that are resident within traditional sources of health care and health settings, or even public health settings. But what's emerging is this, with this ecosystem of social mobile technologies, is an entire new category of data, and it's data about individuals, populations, free-living individuals that's being incidentally captured, either by virtue of the digital traces that people use or voluntarily captured. You know, Pew Foundation earlier this year, 20% of the people in the United States are using some form of electronic device of some kind to monitor some form of health-related parameter. Another 30 to 40% are monitoring in one way or another, not yet necessarily digital, but ways that might become digital in the future. So just finally, I'd say one of my new initiatives is the Robert Wood Johnson Foundation initiative, where we're trying to take all of these things that relate to personal health data and complement what it is that we understand from our traditional forms of data to fill out the entire picture of what represents the health of an individual. And that's where engagement can happen. That's where we really think this notion of truly solving the problems of engagement, and I could go on and on about that, but it's again, the analytics that underlie this brave new world are quite exciting to all of us working in the space.
Well, we'll hold that thought because we'll come back to you. But Dr. Iqbal, at Sanofi, you're thinking about connected healthcare in a quite different way as you think about how your treatments offer value to patients and to payers. So tell us a little bit about your role and what you're working on.
It's really important to make sure that patient centricity becomes part of the study endpoints. Let's say in oncology, you're increasing survival for more than 2 months. But if that additional survival of 2 months comes with the patient in the hospital for 1 month or suffering with grade 3, grade 4 diarrhea for 1 month, payers are not interested in that additional survival. They're not going to pay for that. At the end of the day, you would have an approved drug, but someone has to pay for it. And the patient needs to make sure that the additional survival that is happening is coming without any compromise in patients' quality of life.
So it sounds like what you're describing is a higher bar for evidence in terms of the data that you're collecting and how that then it informs the types of drugs that you're developing and the prices that you seek?
Absolutely. The evidentiary thresholds are changing fast, and they're rising to the level where they should have been, because we wouldn't have seen this situation of brand inflation, of premium pricing for Me Too products, issues that we see every day in the news about the pricing of the products, and is this, are we getting the return on investment in terms of the patients and the providers? So the evidentiary thresholds have increased, and they have increased at the regulatory level with FDA, where you have to actually, the risk-benefit ratio has gone high. From the payer standpoint, where you won't get a product reimbursed until and unless you compare it with the standard of care. Your target population is very geared towards the unmet needs where the new drugs are needed, and they have the patient-centric quality of life outcomes, so that the whole target product profile is delivering real-world innovation linked to real patients.
Stefan, with your work at IMS, how are you thinking about this?
Connectivity, I think, is the key to really get to evidence. And I think there are a lot of hurdles to make that happen. I think the first one is, of course, that you can't just do this, pull the data in. You need to do this in a way that protects patient privacy and so on. So getting to the level where you have a de-identified engine right at the source and connect the data at the source and then be able to connect it on the back end is one of the primary conditions to really connect the data in the right world, in the right way. We at IMS, we have done this for a long time now. We have now over 400 million patient records, patient journeys across 15 countries, 150 million of those in the US alone. And that is the basis for really driving scientifically credible evidence. As it was pointed out before, every patient is different. There is not the average patient. You got to drill down to very unique patient measures. And so only if you have that kind of volume, you can identify the patients that are needed. The second point I think is, as Dr. Liebowitz said, you have to bring it down to where care is happening. So even if you figure out at the top level, what care works, it takes a long time to get it into clinical practice, how you can accelerate that path. And that has to happen by using the technology to codify the learnings that you get at the aggregate level and build it into your local systems. Physicians are not going to spend the time to search for the right patients. It has to be alert systems that alert the physician right at the time as a flag in the system when they're delivering care or during the care process. Flags that allow them to act on it. And obviously, all of that requires the right kind of incentives across the care system.
It takes anywhere between 15 and 20 years for new evidence to actually be adopted and be the standard of care. And I can't help but think that, not wanting to be cynical in nature, that part of it is education. It's not so much reluctance to change ways as it's really not understanding what the evidence is. And I can't help but think through IT, there's got to be a way in which we can do a better job of educating, both long-term as well as in the moment. I mean, we talked about continuing medical education, about physicians being trained to be lifelong learners, and that's sort of the backbone of what happens. But I think that we need to figure out how to use IT in that moment to remind people what the right way to go is. And then we have this sort of yin and yang between personalizing and evidence-based medicine. One of the things that, early on in the evidence-based medicine movement was the comment that it's cookbook medicine. And it's really not cookbook medicine, obviously, but what evidence-based medicine tries to do is, number one, identify those people for whom studies exist that really address this issue. And then through standardizing the way we take care of patients through evidence-based medicine, we can deal with probably 80% of what's going on. And if we have the standardized care, if we take away this unwanted variability and we can really get that 80% under control, it really frees physicians to look at the rest of the 20% where this patient is different and then try to understand what evidence exists there.
Kevin, did you want to build on that?
Add to that, and what's exciting about, again, the new forms of IT, both the IT that's in the cloud, but the IT that people are wearing, is that these mobile devices and wearable devices are both measurement tools and intervention tools, and they provide continuous measurement rather than episodic measurement. Medicine, and I practiced it for many years, it was you saw your patient every 6 months, how you doing, this, that, and the other, capture some information, and course correct based upon that. That's nonsense if, in fact, you're managing something that could be influenced by a variety of factors. We have now wholesale moved into an environment where we can take continuous measurements on a variety of things. So, massive amounts of longitudinal data creating huge challenges to the data scientists in the room that understand the complexities of this. But this is where we're working with control systems engineers now, because control systems theory is actually what we're beginning to apply. Because if you get continuous measurements on individuals, you don't need to wait 6 months or wait a year to figure out what's going on with someone. And those continuous measurements can be both objective, passively captured data from this computer that we're all carrying in our pocket, to periodic assessments. You can stop and ask a question or two. You can actually get into affective state, or you can get into a variety of things through ecological momentary assessment. So you can get at some of the very important things that people were talking about how do you feel, and how is your spouse doing, and is this influencing an important aspect of your life? So basically this picture is getting pixelated in the way that we have always needed it, but never had the ability to have.
How do you see the two somewhat parallel trends that may or may not converge of these consumer apps that were referenced by Sati, where you have just an infinite number that seem to pop up in the App Store every day, compared with the apps that are going through the 510K process through the FDA? These are much more part of an integrated system of monitoring patients at home. You see companies that have had no traditional role in healthcare being really aggressive in this space, whether it's a Verizon or an AT&T. Do you see the consumer side of mobile health intersecting with this medical side?
Oh,
how do those trends converge?
Absolutely. And in fact, I think it's almost safe to say that the consumer side right now, we're giving people practice. They're sort of getting practice about using these devices and whatnot. So this is good practice. It's sort of, hey, what can you do? And this is smart. And we've all seen it, with our parents or with other people. I mean, this is across the age spectrum about getting people to become familiar with these ubiquitous computing technologies. So this consumer effort has actually been a good thing. And I think what's happening is that they're winners. There are some things that are emerging in this ecosystem that are going to be quite good, and they'll be picked off by the various companies. We see Aetna Care Pass, for example, is doing some work in this area. Others where they'll be sort of best of breed. And a lot of us are saying there'll be a shakeout, and there ultimately will be key sort of more dominant platforms. You know, in the U.S., there were 2,000 automobile manufacturers at the beginning of the industrial age. Now we have a few dominant ones in the U.S. and abroad. So I think this will come forward, and I would say that the FDA is not necessarily going to lead this. What the FDA is doing is helping with some of these things, either a specific app for a device or something that is to be used to compare it with the device. But I think we're going to see a lot of excitement, and this is what the RWJ project is about, is in getting these companies like Jawbone, like WebMD, like others who are very involved in Fitbit, who are very involved in capturing these data, begin to sort of recognize the importance and power of these data as adjuncts to what it is that Dr. Liebowitz, a diabetes specialist, might need to know about. How active have these people with diabetes been, and what can we do about those who have not been active?
Dr. Liebowitz, you referred to the desire to have evidence-based medicine translate more quickly, have real-world evidence translate more quickly into changes in clinical practice. What are the tools that you find most useful in that endeavor? What are the missing tools? Where are the gaps? When you look at your goals for what's a very big hospital system, what are the areas that you find exciting with the technology we have today, and what are you really hoping tech companies will bring forward to help you?
Yeah, unfortunately, I don't think there's much in the app world that I can point to in terms of what does it well. I think that the key thing that I'd be looking at is clinical decision support, and really having that point of care ability to understand what the current evidence is. Part of what drives particularly non-physicians crazy, the general public, is the fact that evidence changes. And so, before the Women's Health Initiative, estrogen was a great thing, and then it doesn't. So the public gets a little confused in terms of where we go with this. But I think the key thing is really incorporating physicians into the process as they're working with the patients and making it very easy for them to know what the current state is. We're currently working on an initiative in terms of creating clinical pathways. This, again, we've talked about things that go back to the 80s. This was back in the 80s. We're now bringing it back, and what we're trying to do is integrate it into the EHR. So as I said, we can take care of those things which are very common, those things which you can use 80% of the time. And then the deal is when they're not in that 80%, how can we identify why that patient's not in the 80% and the different approaches that you can take in terms of dealing with it. I think that this is an area, if I were working in IT, where I would be spending a lot of my time.
If I may add to these points, the fact that we have 40,000 apps on the App Store around healthcare is actually a great thing. It creates a lot of opportunity to learn. I think the key is that we want to figure out what the real result is. What is the scientific outcome of these? Do patients truly get more engaged? Do we have really better results of it? Judging these apps based on the number of downloads or the number of positive reports by patients around them doesn't really mean anything in clinical practice. Maybe they give a sense of how much patients like them and engage with them, but they don't really tell us the results. So the important thing is, again, with these apps, that you actually connect them to the other information around patients, how patients who are using those apps, how are they actually ultimately being treated, how engaged they are with their treatment, and ultimately what the outcome is. Only then we really get to a point where we can say these are the right apps, these are the apps that we should be prioritizing, and then put them in the arsenal of the physician to actually prescribe. I think the NHS had brought out this statement, an app a day keeps the doctor away, right? So only then we can really figure out which are the right apps.
Yeah, if I could comment on that, what these are doing, they're actually challenging the research methods that we have used for decades. I trained in epidemiology, I trained in biostatistics. Those methods don't work in this new world of throwing these apps out in the environment. You have to use, again, continuous longitudinal data, machine learning, a variety of things. In the behavioral theories that we're working on, there are researchers that are actually beginning to develop much more compatible approaches to match up with the evaluation of these successively, iteratively, in real time. And so I've sort of seen this happen. Behavioral economics, there was a comment or a discussion earlier about the behavioral economics aspects and the fact that if we want behaviors to change, we need to incent them. We can actually do small, micro-scale, iterative experiments now using these devices that we were never able to do before, and mix and match and design studies in different ways. So it's, as a researcher, again, this is actually very exciting to think about moving into this world that we're talking about. So again, this is challenging for us, and I'm kind of a cups half full person. The challenges are not overwhelming us. We're taking them on and really trying to build the evidence base for this.
Usman, did you want to add to that?
I just wanted to link it back to what we talk about big data, because the same challenges you face that you're facing with the apps, with the big data, it's a buzzword out there, but we deal with big data every day, and when we're talking about big data, we want to assess treatment patterns and patient journeys at the national level, across like 8 to 10 key markets at least. So we're not basically structuring ourselves to small centers or small hospitals. So that's where big data is becoming a buzzword, because it's really not about the size. It's about the scope. It's about the velocity. It's about the generalizability. And most importantly, I think, as folks talked about, the ability to link different data sets at the unique patient identifier level so that you can track patients across all sites of care. You have a big claims data. All it's going to provide you is what the patient got in terms of what was paid for. That's not enough information. You need clinical data. You would provide it with the EMR. But if you have just the EMR systems, you won't know what is happening at the claim level. So you cannot link the clinical information with any economic or any CPT or procedure codes. What is happening in the hospital, if it's EMR-based database, if the patient got admitted into the hospital, you won't be able to link that. So in order for you to do a full landscape, patient landscape assessment at the national level, or at least at the regional level, you need to have a very linkable data set that can link patients across claims, across prescription, across EMRs, and then be able to have customized chart reviews. You want to get more clinical granularity. And that linkability is the key to big data. There's a lot of buzzword out there with a lot of misrepresentation in terms of what the capabilities are. It's not about the size, it's about the scope, the velocity, the generalizability, and its ability to address the questions that you're trying to address as it relates to research.
So get your questions ready. I'll ask one more question to the panel. We haven't talked about health exchanges. I mean, we've talked around the subject, but this was something that people were excited about, that this was going to be a new age of sharing of information. What happened with the health exchanges? What's the current state of affairs? Somebody, Dr. Liebowitz?
So I live in New York, and New York is actually out in the forefront. New York had a $500 million program in terms of doing it. We've got a significant number of hospitals who signed up for it, but it's in its very early stages. It's an opt-in, not an opt-out system. And we are actually at New York-Presbyterian taking part in it, and we're starting to get data from it. So I think where it goes is yet to be determined. But again, I think the issue is going to be the data will come in, but how do we get that data presentable? How do we get it to the physician who's sitting there with the patient in the hospital, in the outpatient area, and how do we use it?
Yeah, I would say San Diego, we too have one of the Beacon, one of the ONC-funded Beacon projects that's a success like yours.
And just to clarify for the audience, it's the Office of the National Coordinator
Yes.
gave these grants to different communities
Right.
to help push forward the
Right.
initiative.
And in San Diego, we have this sort of accident of history that we have, Camp Pendleton to the north, Mexico to the south. We've got the desert to the east, and so we're sort of in this sort of zone where everybody, for many years, has already cooperated a bit with one another. We have Kaiser, we have Scripps, we have Sharp. And so there is some exchanging of information, but it's a socio-technical political challenge. I mean, getting everybody to the table who, in fact, every year compete for one another's patients in the open enrollment periods is a challenge. But we're hopeful. We're succeeding in some respects. And what we're particularly interested in is not just the health information exchange for the medical record, but it's adding in these other forms of data. So we've got an NSF-funded project where we're looking at additional forms of data from wearable technologies and whatnot, because that's, again, the picture that I think is going to be most valuable to the developers of the apps and services that might want to be serving the 3.1 million people in San Diego County. But it's sad, we've talked about this. I developed the All Kids Count immunization registry in San Diego 15, 20 years ago, and it should be further along. It's not, and I think it's one of the...
Why isn't it? What's the...
Socio-political, technical. It's not a technical issue. It is the issue of it's a structural thing.
You could say that about the entire American healthcare system. Any questions for our panelists from the audience?
My question is, as we're kind of moving into, first off, John Moore, Chilmark Research. And the question is, as we're moving to this kind of more consumerism in healthcare through health insurance exchanges when eventually those come out, consumer-driven health plans, et cetera, and mobile devices, apps, what have you, pushing more responsibility into the consumers. We're also starting to see consumers taking some responsibilities on their own in sites like Patients Like Me. And this is where they are actually having numerous patients in given disease states, particularly ALS, basically doing their own clinical trials. And this is being driven at the consumer level. So my question is this something that we don't always have to look for that best clinical evidence coming from someone with a PhD or an MD behind them, behind their name or some sort of alphabet soup, but maybe from consumers with some sort of specialist on top of that looking at the data and actually making some sense of it and then deriving some results from that? And how do you see this actually impacting the delivery of care going forward and, for example, the research you're doing in oncology? Thanks.
Well, I don't think you can call sites like Patients Like Me as patients doing their own clinical trial. The clinical trial environment is a very strictly regimented, controlled environment where in order to see an effect compared to your product, you have to fulfill a lot of criteria that you cannot see in the space around Patients Like Me. What you can do is that you have a lot of data coming from a lot of patients, and it's something that can be leveraged to inform your clinical trials in terms of your hypothesis generation. If there is, let's say in mental health, there is a use of Depakote for multi-purpose mental health disorders. You can actually design a clinical trial based on actually a pragmatic clinical trial based on different patient populations and see if the product that is basically approved for depression works in bipolar. Same is with A1C reduction in diabetes. If it's the surrogate marker, but patients are using any kind of product, it's leading to better weight management, better metabolic control, it's better physical function. You can add those endpoints to the existing clinical trials and see let's see if it works. So the only way you can assess these sites like Patients Like Me, and we are working with these sites as we speak, to understand how the patient is behaving and what are they thinking and what are their needs are, and basically incorporating that learnings back into the developmental strategy, into the clinical trial endpoints, and making sure that the hypothesis that we drive from these patient pools is basically translated into a rigorously driven, empirically designed clinical trial. So
the social media, if I may just say, the social media data is providing another very powerful opportunity. In fact, there is more unstructured data in the social media out there than structured data in EMR systems. And they can provide an opportunity for signal detection, whether it's adverse events or, in fact, for what works. I think the critical step is saying, okay, can I take the data, first process it, really validate it? I think we are not there today in terms of processing technology that we can really understand sentiment, yes or no. It has to be, I think we can categorize and structure the data. It needs to have still some validation, but then we need to bounce it off against real-world evidence.
Yep.
And saying, how real is what the patients are saying? Is it really matched in what types of patients, and what does it really mean? And then it can be funneled into both clinical practice as well as research agendas for pharma.
Dr.
I was just going to pile on and agree, and I think putting it in the rubric of evidence-based medicine, there are all levels of evidence. This is a level of evidence that would not change clinical practice, but would clearly be excellent in terms of hypothesis generation and put it into the context where you can test it, study it, and then, if positive, move forward.
Yeah, and I would say that our recent environmental scan of this space, of interviewing over 450 individuals, many companies and researchers, this isn't a fad. There are a lot of signals out there. Chronology, Sean Ahrens created, people with Crohn's disease. One of the co-founders of 23andMe, Linda Avey, who's on our advisory board for this project, has created a company, Curio.us, of affinity groups. So this is a pretty strong signal, this notion of sharing data for purposes of collective good. And we found a very strong sentiment among the individuals who we surveyed on this in a national online survey, that again, this is a trend. So it bears watching and bears paying attention to. And again, like everything we talked about, would vector into what it is that the other issues that we're talking about here today and potentially help shape the future.
Hi, Lori Fontaine from Hologic Clinical Affairs. sort of as a follow-up question, I guess. You talk about evidence-based medicine, the need for better clinical decision support. Can you comment on the impact of NICE in the UK and whether or not such an organization in the United States to centralize evidence would be of benefit?
I don't know how, it's like arguing against mom and apple pie. Sure, I think it would be a benefit. It's in the where and the how, I think, is the question.
I think, as a moderator, I'm not supposed to answer a question, but I think that if you see,
Break that rule.
if you see what happened with the Patient-Centered Outcomes Research Institute, which was set up by the Affordable Care Act to look at comparative effectiveness and the way in which it was neutered to not even be able to consider cost. If you see the reactions to the United States Preventative Task Force when they issue recommendations around cancer screening, for example, and you have just complete fits across news stations, I think that America has a very unique relationship with evidence globally in that we don't like to pay attention to it. The Choosing Wisely campaign, which I'm sure you're familiar with, which it was groups of physicians advocating to actually pare back from certain procedures that don't have strong evidence behind them. I think that's really interesting and maybe the seed of what could be to come in general comfort with considering evidence. But the conversation that, from my vantage point just as an observer in different markets, the conversation that we're uncomfortable having publicly in the United States happens privately already by payers, right? And it happens privately when PBMs are creating their formularies. So there's a disconnect between practice and the national discourse is what I've observed. I'm not sure if any of the panelists would care to comment.
I mean, yeah, absolutely. I mean, whatever the government says or your cost cannot be included in the comparative effectiveness paradigm, that's something that is pretty much on the surface, on the papers. But if you see every big payer, we're talking about the United Healthcare, the WellPoints, I think there's some of them are over here. They have their own HTA assessment paradigm, which include cost, which includes health economics. You're supposed to provide cost effectiveness models, which would tell that your product is not just effective, but it's also cost effective. The threshold that is in the US is being used is $100,000 per quality adjusted life years. So, I mean, cost is going to be part of the equation. It is considered as part of many of the US healthcare system as it relates to the commercial payers. And I think the day is not far when every other entity out there would be talking about it, at least at the back end, even though if it's not in the papers. So the decision making is influenced by cost. But we have to understand that cost, you cannot take it in a silo. It's about cost, and in return, what are you getting out of that? So it's cost on the basis of what? So that's where value-based pricing comes into play. If you're delivering that level of value that justifies premium pricing, then yeah, cost has to be discussed in the backdrop of that situation. So it's not going to go away. It was never there to go away, and in the future, it's going to play a much, much bigger role.
I think people's discomfort is around the generalization of these clinical rules, right? Healthcare or treatments, you know, nothing works in every patient, and there's almost nothing that doesn't work in some patients. And the discomfort comes when a rule is generated at a certain aggregation, and people feel that, you know, it may not apply to them. So getting down to very granular patient population definitions is absolutely key, and I think that that has never really been, I think, well articulated and well defined as a goal, and what is an acceptable standard in terms of population definitions, and I think people are worried about that.
I think that this is a really interesting discussion. Hope to continue it with each of you selfishly in the future. But thank you so much for being here. Please thank our panelists.